Okay, we'll begin. Again, this is being recorded. Thank you everybody for joining us. I'm going to start sharing my screen. And too far ahead. All right. So thank you everybody for joining us. My name is Matt Beyerschmidt. I am the Senior Program Manager at the National Nurse-Led Care Consortium. This is the first session of the Public Housing Toolkit. And forgive me, we were putting slides together pretty quickly just to finalize things, so I don't have an intro slide, but I'll get more detail as I move further along. Today's the first session of 4 sessions. Some slight housekeeping. We're recording the Zoom today. Captions, to adjust or remove captions, click the live transcript button at the bottom of your Zoom window to hide and select hide subtitles or show subtitles. Feel free to ask questions, pop them in the chat, raise your hand. We will leave time at the end for Q&A. If you're having technical issues, please raise your hand and let us know, or message one of the me or one of the other team panelists for assistance. And again, this recording is happening for the session. So all of the recordings, the presentations, and resources will be available at the end of the session, and we will email them out to you. And we will also have a Google site that we will share out with all the modules, all the sessions, and all the content you will need for today and moving forward for the next 4 weeks. We are providing continuing education credits. You may earn 1 CE credit for this activity. We are, after this session, you will be emailed. The CE credits are a little delayed, but we will send you a survey in about a few days after the completion of this course, so you can take that and get CE credits. So please let us know if you don't receive an email from us in the next few days, but you will get an email about CEs for this current course. And then moving forward, we'll have an automatic survey afterwards of each session where you'll be able to receive credits immediately after the course. But this week has been a little delayed on the certifying body end. So we will get out the link for your CEs within a few days after today's session. Today's session is a collaboration between the National Nurse-Led Care Consortium and NCHPH. We will go into a little further into that. In the next slide, the National Nurse-Led Care Consortium is a membership organization that supports nurse-led care and nurses at the front lines of care. NNCC provides expertise to support comprehensive community-based care through policy research, advocacy, technical assistance, support, and direct nurse-led healthcare services. NCHPH, or National Center for Health and Public Housing. They are supported by the Health and Resources Service Administration of the U.S. Department of Health and Human Services. The mission of the National Center of Health and Public Housing is to strengthen the capacity of federally funded public housing, primary care, health centers, and other health center grantees by providing training and a range of technical assistance. NCHPH and NNCC are both NTAPs, and we provide training and technical assistance for health centers. And our NNCC's focus is health centers that serve residents of public housing, and NCHPH's TTA is focused on housing and public housing. So I'm going to popcorn this now over to Dr. Lombardi. He'll begin the session, and he will let me know when to progress slides. And we will pin him at the top of the screen so you'll see him. And thank you again for joining us, and have a great session.
Hi, everyone. My name is Dr. Kevin Lombardi. I'm a medical doctor and an epidemiologist. I currently serve as the manager of health research, policy, and advocacy at the National Center for Health and Public Housing. If you could stay on, yeah, no, just stay put for a second.
I hit the wrong button. My bad. You're fine.
Okay. I'd like to thank you all for joining our Learning Collaborative on Public Housing and Partnerships. This is an uncertain time for many in this field. The end of the COVID public health emergency and Medicaid turmoil in many of the states has led to a great deal of uncertainty in many of our constituent organizations. Inter-organization partnerships are an important tool in facing challenges like this, and they also help create resilience for future issues as well. So we're very excited to be able to delve into this topic in detail and share as much as we can. When I like to think of collaborations and partnerships, I think of them as prophylaxis for uncertainty. They are resilience builders, and they're important tools in the box of any administrator or health center worker. They're complex though, and creating, maintaining, and evaluating partnerships is complicated. In the short to medium term, they require human and fiscal resources, and managing that and being able to provide some sort of certainty in how much that will be is a major challenge in deciding if these are even viable for many organizations. Our hope is that by increasing your understanding of this topic, specifically the systems and processes that help to manage these relationships well, that it can open up opportunities for you and your organization to perhaps strengthen or create new collaborations in your field. There will be some changes to the learning objectives throughout the course as we gain availability to subject matter experts who have practiced this in real life and have a realm of experience to share with us regarding specific types of partnerships and the strategies to maximize your yield when considering one. Next, please. The mission of the National Center for Health and Public Health, very briefly, is to strengthen the capacity of public housing primary care grantees. The next couple of slides have some data that I will briefly look over. The next one, please. Is some data on our grantees. For those of you who have seen our sessions before, this information is not new, but the takeaways being that this is a large population that disproportionately uses RFQ-HCs and has a number of characteristics that make them more vulnerable than the general population. For that, they deserve our attention and our respect. Next, please. And our demographics on the public housing population. The important things to see here are that demographically speaking, public housing population is different than the general population. They're disproportionately led by women-led households. They're disproportionately disabled, and they're disproportionately from historically underrepresented groups. Next, please. Learning objectives are going to be a little different today, but what we will be doing is we'll be breaking this into three main parts. I am going to briefly go over some of the main HUD programs and the main USDA programs that are ripe for collaboration. I will kind of briefly give an overview of them. I will then pass it over to Jason, and he will speak a little bit about his perspective and how health centers can maximize their relationship with HUD. And then we will go to our health center partners who will give us their perspective as well. We'll be going from the broad to the focused. Next, please. So our section 1, overview of community partnerships. Today we'll be going through what I stated, and next session we'll be going through some of the strategies and definitions. This learning collaborative will utilize the framework from the Healthy Together Toolkit. There's a link here. The link will be on the site, I'm sure, as well. The toolkit was created as with our two organizations, and essentially is a step-by-step guide to how to understand and make partnerships happen in real life. We'll be drawing from it heavily and referring to it throughout the session. Next, please. So let's talk about our population focus. In this LC, we'll focus primarily on residents of public housing as our core demographic to kind of focus our scope here. However, reviewed information will also be relevant to health center staff, administrators, and advocates who serve health center, who provide care to HUD-assisted adults and individuals with insecure or transitional housing. These populations demonstrate some key demographic, geographic, and social characteristics, which makes it make sense to put them together in this framework. Next, please. And for our program focus, these are the main programs that I'll be briefly looking over today. Here and on the left side here is a kind of a breakdown of the budget in 2019-2022 of where HUD puts its money into its programs. So we can see the largest programs, housing, vouchers, and project-based Section 8 are programs hopefully we've heard of that have a pretty significant presence throughout the United States. So to go over some of the bigger ones, the housing choice vouchers were formerly known as Section 8. These are vouchers that allow very low income families, the elderly and disabled, to obtain and maintain housing. In general, to remain in the program, family incomes can exceed 50% of the median income in the area of which they live. And by laws, PHAs must provide 75% of its vouchers to families whose incomes do not exceed 30% of the median income. Next one, please. Project-based Section 8 housing, another large program, I think the second largest on their allocation list, that provides rental housing to low-income households in privately owned and managed rental units. These rental units are designed for the subsidy, which stays with the unit. When the tenant leaves the unit, their membership of the program ends. Generally, the rental costs for these units are about 30% of the adjusted gross income of the tenant. And housing types vary from single family, townhouses, apartments, depending on the geography of where it's applied. Next, please. Another program, and just briefly for those of you who like looking at the details of data, there is some on that previous slide that looks at the data related to program administration. HUD-VASH is a collaboration between HUD and the Veterans Administration that provides housing vouchers to homeless veterans and their families. Next one, please. And the Family Self-Sufficiency Program, HUD program designed to help public housing residents, HCV voucher participants, and residents of multifamily units to increase their resilience. I have a link here to a guide for those of you who know the program and would like more details. Next slide, please. Jobs Plus program is the purpose of the initiative is to develop locally based job-driven approaches to increase earnings and advance employment opportunities through work readiness, employer linkages, job placement, educational advancement, and so forth. I've got details on the program requirements and reporting linked, and the Job Plus NOFO for those of you who are aware of the program and interested. In Section 202.811, it's the next slide, please. Excuse me. These are programs you may have heard of. They are for elderly and disabled person. There's also HUD-specific programs that are for persons with AIDS as well. Next slide, please. And to transition from HUD, USDA also has a presence in housing in rural areas. The Rural Housing Service, which is sections 515, 521, and 538, offers single-family and multifamily housing programs in rural areas. So that's the overview. I'm going to transition now to Jason, and if you don't mind, I think he'll be sharing his screen. So thank you.
Great. Thanks, Kevin. You all can hear me okay? Wonderful. Kevin just really gave a great overview, I think, of HUD programs and some of the programs that I work on in our Office of Community and Supportive Services. We consider ourselves the people at HUD. So a lot of times when you think about public housing and you're thinking of housing, as the physical stock, we actually also fund folks whose main primary purpose and role is to connect residents with resources, including, chief among them, health resources. So these are folks who may be really eager to partner with you, and perhaps you already have existing relationships, and we help to support that through our grant funding and technical assistance. So I'm not going to do too much time on repeating what Kevin said, but I'm just going to share that there are different types of federal housing assistance, and it can often be a little opaque to a health provider or other community partner as to the difference. So It's not so important for most of our programs that you even know, but it is important to know that there are changes that are happening. So you may be used to thinking of public housing as the primary vehicle for housing assistance, and that is changing. For decades now, there have been housing choice vouchers, which are actually able to be used at the housing of the resident's choice. So those could be located anywhere in the community. And then more recently, we have been converting a lot of our traditional public housing that is managed by public housing agencies to multifamily project-based rental assistance, or PBRA, properties that are managed by, in some cases, PHAs still, but in other cases, nonprofits or private entities. They still have to be maintained as affordable housing, but sort of the back end of how those are operated and managed changes. So I think, you may hear these terms, but what's important to know is that anybody who's living in any of these types of housing, in addition to LIHTC housing or other types of affordable housing, are going to share many of the same needs and are going to have many of the same resource constraints because of the income limitations for folks who live in assisted housing. So, just as kind of a thought exercise, we often think about the need out there, and that we meet about a quarter of that need through our programs. So 3/4 of people who are burdened in terms of their housing costs. So, over 30% of their income are ineligible because of either waiting lists or lack of congressional funding to receive federal housing assistance. So beyond just these different types of housing assistance, there are many folks who may be living in adjacent communities without housing assistance who have many of the same needs. So, I would really encourage you all, and I'm sure you do this already, to think broadly about patient populations and, assisting communities beyond just like checking a box that you're helping someone who happens to live in public housing. You can tell from these statistics that a large portion of our residents are children. So we often think about, mothers with children as being some of the primary populations. We also have senior housing, disabled housing, and then there are working age adults. But if 40% of our population is children, I think that's relevant also from a partnership and a health perspective. So, we think at HUD about housing as one of the social determinants of health, and I'm sure you all do too. So, when folks have health needs, it could be in some cases, unfortunately, caused by the housing. We have an Office of Lead Hazard Control and Healthy Homes, and their job is really to work on remediating things like mold or pests, and also, reducing lead exposure risks, whether through paint or pipes. And so, we're thinking about it from that angle, but also we know that having access to affordable housing can really, and it's stable and secure, can really improve the health outcomes of folks. And so sometimes what people may be experiencing from a health perspective could be the result of not having access to that housing. So, within HUD, we're very siloed, but our Office of Community and Supportive Services, we are now expanding to not just assist public housing, but we, for the first time this year, have started to make grants toward those multifamily housing that I talked about earlier, the PBRA, project-based rental assistance. And we also continue to serve voucher households and some other populations. We have tribal housing within our office. And so, many cases, if you're working with someone who's a resident services coordinator or let's say a social worker, they may be funded by our office, our programs. And so this is just a picture of some folks on the ground from one of our programs called HUD Strong Families. And prior to the pandemic, we used to really focus on in-person events in May and June for Mother's Day and Father's Day and reconnecting families. And, I really want to encourage you all to think about, if you haven't already, visiting an affordable housing site to really get a sense of what it's like on the ground. I think people often have perceptions, maybe even stereotypes or ideas of what it's like in certain areas. And, visiting, and I know many public housing agencies or PHAs would be happy to have you. They're always really looking for partnership opportunities and to show you around the properties, to have you meet residents, even to see maybe inside of one of the unoccupied homes to get a sense of what the homes are like. I think it really is important because it gives you a context for the lived experience of people in the community and where they're coming from. So, in some cases, you may go and be surprised at just how new and refreshed the housing is. And in other cases, you may go and be disappointed perhaps in maybe the needs that are there and that are currently unmet. And, hopefully in many cases, we're trying to provide them with the resources to remediate that housing, but, that's based on congressional funding. So this is just a map of those investments that our office supports. And you can see much of it is concentrated on the East Coast, but it is spread throughout the country. And so we have over 3,000 public housing agencies across the country. There are, thousands of multifamily owners. And, so it sort of mirrors the general distribution of population across the country. I think Kevin really touched on our programs, but I'll just talk about some of our big ones again. ROSS is our Resident Opportunity and Self-Sufficiency Program. This is a program that funds service coordinators. So we are paying somebody to work with residents to connect them to services. So these are great people for you to work with because they could help connect, for example, folks who have health needs. We did an analysis of health needs among ROSS served populations and found that there were significant gaps. And maybe those gaps aren't things you can directly address. Some of those involve things like dental care, which is lacking. But certainly we think of the FQHCs as being like the first line of defense in terms of primary care, and that's only proven more and more so during the pandemic. We also have Family Self-Sufficiency, which is the program that I help to run. And that program is focused on helping people achieve their financial goals. So that's through a combination of education and training. And you might think, well, where do we fit in there? Well, one great way is that health careers are actually some of the biggest growth opportunities and areas of interest for our populations. So I always encourage, health partners to think about housing populations as potential employees, whether it's as a community health worker, and I'll talk in a second about some of our success there and what we've learned about just the importance of community health workers in our communities, but also, we know that a lot of folks at very basic levels are looking to get lab tech positions, pharmacy tech positions, but also to work their way up. And we've had folks go on to become nurses, PAs, doctors, the whole gamut. So I would encourage you all to think about that as a population that if you're trying to reach folks, some of the best ways can be to have people from the community who are actually hired or working for you. And of course, the other way that I think about it, and I'll talk more about this in a second with Jobs Plus, is that we know some of the barriers to people achieving their goals can be their health needs and their unmet health needs. And so, it's really important, certainly for our populations, to have the healthcare that they need to ensure that they, can go to a job every day, that they have what they need, whether it's physical or mental health. I just mentioned Jobs Plus. That's our third sort of big program. This is an intensive program. So this is a multi-million-dollar grant for 4.5 years. And it really is sort of like our biggest and best program in certain ways. So, FSS, we're funding, some coordinators. ROSS, we're funding coordinators. Jobs Plus, we're pumping millions of dollars in terms of rent supports, in terms of staffing up, and partnership. And so, we announce these awards usually about once a year. We just had a cohort of 4 new sites. They're located across the country. And in varying communities. So we have in our newest cohort, Oakland, California, and also Brunswick, Georgia, right? So there's some places that are big city, more rural in all the different regions. And if you're in an area where they did just get a Jobs Plus program, again, this is a ready partnership opportunity because in many places, they might be used to having a resident services team of 1, and you're now talking about a team that could be, half a dozen, right? So that's just something that we're very excited about. And it's of course based on the cost, limited to a certain number of sites, but those are ready-made partnership opportunities. Beyond those sort of core funded programs, we also have Connect Home USA. And I'll say, you may be thinking, well, what's the importance of connectivity? I think during the pandemic, we all learned, right, how important it was, not just for, things like education, but also for health, accessing telehealth, getting information online about COVID, about other infectious diseases. And so we have worked with now the FCC through their Affordable Connectivity Program that provides a $30 a month subsidy. And they also have a pilot program called Your Home, Your Internet that pays for community navigators, people to go out into the community and market this program to increase uptake. This was actually first piloted in Los Angeles. And I mentioned the connection to health because it started as part of a community health worker program. So we launched a CHW program in LA, which was a Jobs Plus site in 2019. And quickly during the pandemic, they realized, one of the needs as a social determinant of health was connectivity. They were looking at pretty low rates. At that time, it was the emergency connectivity program. Now it's the affordable connectivity program, but they were having low rates of uptake. And nationwide, we saw that this is, in many cases in like the teens. Well, they went from 8 to 80% uptake just by hiring ambassadors, which were the community health workers, to market this program. So they saw the impact and the benefit to the community. The FCC actually saw this, and they took that model and scaled it up. But I think what's really important to take from that is at its core, it was recognizing the value of the trust and the relationships that community members have, and leveraging that to meet the larger goal of connecting the community. And that same model, of course, is the community health model that we believe is so important for health. We have a lot of education initiatives. I won't go into detail here, but just know that because we recognize 40% of our population is children, we do a lot of outreach around things like SNAP benefits, around, SCHIP, around all the sort of, youth-focused programs that have a direct impact on health. And so, many of our PHAs have folks who, you may not think of them as ready-made health partners, right? You may think, oh, okay, well, their title is, youth ambassador, but that's a ready-made person who can help connect you to ensure that kids are getting their childhood immunizations, right? That they're just up to date with what they need. And that's just as important for children, in many cases, more so than for adults. We also have, you can see here, initiatives around reentry, financial literacy, which is really important right now, especially during tax season, and just with inflation and things that are hitting our communities, ever harder. And then I mentioned the CHW Path pilot program that we started. So, all of this is to say, if you go to any affordable housing provider in your community, odds are they have somebody whose job is to work with people. They have people, and they really do want to work with you. I know that was a quick sort of breeze through our programs, but I'm really excited to talk with you all about some of your questions and concerns around partnership, and about ways that you can deepen your engagement with affordable housing communities.
Thank you, Jason. If you can give back the screen, that'd be great. And then also, we will have some time at the end for question and answer. So I just want to go back to sharing my screen, and I'll bring it back up. There we go. View. Come on. Slideshow. All right. I want to introduce our next speakers. Dr. Asante Hills, MPH. She has her PhD in public health, and she's the current CEO at Valley Healthcare Systems. And then we also have Latrice Johnson, MPH. She's a registered dietitian at West Central Health District and the WIC Nutrition Service Director at the Georgia Department of Public Health. And we're really happy to have them here. So I will kick it over to them now, and they will let me know when to progress the slides.
Thank you so much, Matt, and we're excited to be here as well. And Jason just gave a wonderful segue as to why it's important for us to partner with some of those people at our housing authority locally. Latrice and I are in Columbus, Georgia, and I have formerly worked with Latrice at the health department in the West Central Health District, but now I am at a federally qualified health center. Our community health center is Valley Healthcare System Incorporated. And we actually have our clinic directly across the street from one of the housing authority housing units. So Latrice is going to share with you about her partnership with the housing authority and now how they have brought public health services, primarily WIC services, to the health department as her priority focus, and how Valley Healthcare System has worked not only during COVID to bring vaccinations and other health services, but now kind of, post the pandemic, how we're working to bring other additional health services, including dental services, to those housing units. You can move to the next slide. So these are just a couple of the Columbus Housing Authority locations, and we have established a wonderful partnership with the leadership in the Columbus Housing Authority. EJ Knight Apartments, Elizabeth Candy Homes, Farley Homes, and Arbor Point, and that's a mixture of senior homes and non-senior living homes. They're all around our community area, and what we have done is we brought some of our mobile units to these sites. It's one of the things that we have learned in just having our community interactions is that people may not necessarily come to our physical buildings at the health department or our community health center until they have established some rapport with us, or there's some other barrier that prevents them from getting to us, like transportation or the hours of our operation. So the mobile units allow us to provide an extension to meet people where they are and to bring our services to them in the area that they live. And that also allows us then to understand what their additional needs might be. The Valley Healthcare System also has a fleet of transportation, so we can bring residents in the housing authority over to our clinic once they have established a relationship with us through the mobile unit. Next slide. So I'll turn it over to Latrice. She'll talk about the history of the WIC mobile unit and the relationship that that program has established with the housing authority.
Thank you, Dr. Asante. Good afternoon, everyone. As she mentioned, our WIC, what is called WIC on Wheels, was started in 2015. And during that time, our program, we saw a need for our participants. Many of our participants shared that they didn't have transportation. They weren't able to get to the local health department. Even though the health department was near many of the housing authorities, they still could not get there. And we did some surveys and just assessed the need in that time. And I look back through our history and our study, at one point, there were over 100 clients with children between the ages of 1 to 4 years old who are not receiving WIC services. So WIC services, moms and children from prenatal up to from birth to the age of 5 are eligible for WIC services based off their income. But at that time, we knew at least 100 clients who were living in public housing were not able to receive those services because they could not come to the health department. So during that time, we applied for a grant through the USDA, in which we were awarded in the West Central Health District, as she mentioned, was in Columbus, Georgia. And we're now able to take our WIC on Wheels, our mobile unit, out into our community. We're currently servicing 3 of the public housing. Many of the housing areas here have been renovated, so we haven't started going back to all of them, but we are servicing those moms and those families, and we're able to go to them to provide those needs, to provide the nutrition education, to make sure that those parents are receiving what they're needing, including the nutrition education, the breastfeeding promotion. We're able to take our registered dietitians and our peer counselors who were once moms on the program out into those communities and provide those families with their needs through our mobile unit. And our mobile unit has been in existence since, like I said, since March 2015. And we have seen it grow, and we have serviced hundreds of families over the years. Dr. Asante, I'll pass it back to you.
And I think the next slide is loading. And there's a lot of pictures on it, so that may be a reason why there is a delay. So let's try the next slide and see if that one works. All right, so the previous slide just had a picture.
Let me go back and try again, just one more
Okay.
time. Sometimes the internet's weird. And I see a show anyway. Oh, there we go.
There we go. Okay, so these are the 2 mobile units that we have right now. The one on the left is our medical mobile unit, where we initially started providing COVID testing and vaccines, but we've now extended that to hypertension education, health screening, immunization, basic eye exam, and some other services. The mobile dental unit on the right allows us to provide some exams, cleaning, sealants. We do assessments and teledentistry from that unit. Now, the mobile units are sometimes too large to fit into the spaces at the housing authority, especially our dental unit. So what we have done is partner with the housing authority to allow us to use some of their community spaces inside of the clinic and provide services out of that space. And that's been a great success, especially after the renovation of some of the housing units, because the services and the space that they have in those, the guest center community room is very spacious. It allowed for social distancing, so we were able to still provide the service even if the mobile unit wasn't available or couldn't fit in their parking lot. So when they can fit, it's ideal, and we bring both the units, or we bring one at a time, and again offer the services to the residents, many of which would not be able to access otherwise. The other thing about the mobile units, and Latrice can attest to this as well with the WIC on Wheels, is that it allows us to bring the units out during non-traditional hours, which is sometimes a limitation as to why residents can't get to us during our normal 8 to 5 business hours, because many of them may be working families. So we have the flexibility and portability to bring the mobile units out in the evenings and on weekends. So we can be more flexible with the housing authority to determine what works best for their residents, we can streamline our communication and put mailers out to the residents in the housing authority and to those units and ask them when they would like us to come, or at least give them an update as to when we're coming. We've integrated social media into this so we can blast out messages to those residents so that they're aware of the services that we'll be bringing on site at the housing authority. Next slide. So these are just more pictures of us in action in the community. Just people, you know, we take the mobile units to any housing complex that we can, and we park it, and we allow people to come up and utilize those services. Next slide. And this is just our contact information. Again, we'll open up for questions at the end, but we just wanted you to see real time. And like I put the part in there about when you don't have a mobile unit and you can use a community site, because all of our portable services that are on mobile units, we also pack them into caddies and bring them to the housing authority. But it makes it super convenient, super easy to realize this collaboration when we have the units that can come on site. And that sums up the relationship that we have thus far with Columbus Housing Authority. Thank you.
Thank you, Dr. Asante. Thank you, Latrice. Appreciate you joining us. So we will now open it. Sorry, we will now open it up to Q&A questions. I want to again thank you, the speakers, for joining us today. And please feel free to unmute yourself or drop your questions in the chat, and we will make sure that you get your questions answered.
While we're waiting, Matt, if you don't mind me dropping in some of my own.
Sure.
So I have a variety of for all of you if we have time for them, but I guess I'd like to start by understanding the relationship that you have with the Columbus Housing Authority. Is this like a relationship that's been going on for a number of years? Has it recently changed or expanded? Could you tell us a little bit about sort of the history of it?
So for WIC, our partnership with the Housing Authority started in 2015. That's when we received the mobile unit, and that's when we started going out, and we've been going out ever since.
Okay. Was it related to any like strategic planning of like we were looking to specifically start collaborations in this area, or did it just kind of organically come together?
So it started with the need of participants sharing why they weren't coming to their WIC appointments. They didn't have transportation, and we started surveying where participants lived and noticed that many of the participants live near housing authority or in a housing complex. So that's how it started.
Oh, interesting. So was there a process where you guys were either in your strategic planning or so forth, where you were identifying an issue getting into the community may solve, or like was there an issue where you wanted to increase exposure to the community, or what was the thought process behind that?
Most of the thought process was just trying to figure out why our participants weren't coming. And it also started with a partnership we also had with Head Start, because we were doing that pilot as well, because research showed that most of our participants, as I mentioned, can receive services up until their 5th birthday. After that 1st birthday, they stopped coming. And we're trying to figure out why weren't they coming. So once we figured out, we're talking with Head Start and that program and that pilot program, and the key issue was the transportation.
Okay.
And being able to access the health departments.
What I love about this is there's like there was a process behind all of this, and like a process of identifying a problem. A collaboration was identified that could help cause it, and you guys have had fantastic results. Have there been any challenges with like the communication or growing of the program as things have progressed? And if there has been, how have you traversed those?
So our most recent challenge was actually the pandemic. Once our processes changed on how we could service participants, at one point participants weren't coming actually into our local health department. So we had to figure out how we could still service them. And we honestly weren't able to go out into the housing authorities at the beginning of the pandemic, but now over time we have started marketing again. So sending out text messages and flyers and posting on social media that we are here, that we are back, and making sure our presence is seen. And as you saw in one of those, the picture of our unit, that's why we make sure the Georgia WIC logo is big, is bright, so you can see it has pictures of families, and it has our listings of what we can provide so that we are seen. And I think that was our biggest hurdle, is making sure that we're still seen and seen visible in the community.
And I would add to that, during that time, during the pandemic, when, like, for example, the WIC services were a little bit limited, it allowed an opportunity for Valley Healthcare System and other services at the health department then to bring services into the housing authority that people would not otherwise be able to achieve. So it presented an opportunity to us. It was a limitation to programs like WIC, but then for us to bring medical services, and at that time, it was mostly COVID testing, and then it progressed to COVID vaccination. It was a door of opportunity for partnership with us. And that door of opportunity has now led to the continued partnership to bring those additional services like the health screenings and dental, things that, you know, we had not been doing before. So we went in specifically for COVID, and now we've been able to maintain that relationship.
What I love about this is that you guys have sort of built it like a house. You made this foundation that was sort of solidified throughout COVID, and you've been able to build on top of it with the dental services and so forth. Thank you for the answer and for the details on the case study. I think we have a couple in the chat that have popped in. Rod asked a question of what media have you used to communicate with public housing residents when your mobile unit is going to be at their complex to do WIC?
So when it initially started, it was just flyers, but since then we now do blast text messages. So for example, the text message that went out this morning, WIC will be in a neighborhood near you. We specify where we will be, the times that we will be there, and then we also send out posts on social media, and we continue with those flyers.
And Rod, I see you just put your camera on. Do you want to ask your follow-up to that you just popped in?
Yeah, I was just curious to know in terms of how the FQHC coordinates with the local health department in some of these services, just from a coordination of care perspective.
So I have the inside scoop. You know, I have the advantage because I came from the health department to the FQHC, so the relationship is, you know, is pretty strong between us. And I sat on our FUHC board before I left the health department to come over into this role. So the advantage, and this was disrupted a little bit by COVID, is that we also had the WIC mobile unit come to the FQHC and park and service the clients for WIC services. But because of the pandemic, you had a lot of families that weren't coming into the clinic for a while. And so again, we didn't have a lot of foot traffic coming onto the WIC unit. So we have been in discussion about reestablishing that. So in addition to the WIC unit going to the housing authority, it'll also come to the FQHC again to try to make the services that the families receive at the FQHC comprehensive. So while they're there, you know, they can get their medical care, they can see pediatrics, they can do vision, pick up pharmacy, and get their WIC all in one location, make it more accessible to them.
Great.
And I think David, I had a David B. We had a question who. Oh, I'm sorry, Rod. Did you have a follow up to that?
I don't want to. I'll let other people ask questions. I have other questions, so.
Okay.
There's time, Rod. You can do one more if you want.
Go for it.
I'm just curious. So the community we serve here in Michigan, the name of the community is Albion, 7,500 residents. The county, the building that we own and manage is houses the health department for that side of the county, as well as the FQHC with the dental services. So one of the strategies, and we, the Albion Healthcare Alliance, we have 2 community health workers that support the work, but we do this through a collaboration. It's not, you know, there are no formal agreements. So I'm trying to understand from a coordination of services for smaller communities like this, where health department, FQHC might not have the staffing available in these smaller areas, where we can develop more effective partnerships using our community health workers to do some of these services, because we have a number of public housing units in the community that we already serve, but it could be much more coordinated and collaborated. Does that make sense?
It does make sense. And Staffing is a challenge for us too, and Latrice can attest that it's a challenge for them as well. But the coordination probably is the most critical component to that, because each organization, in your case, the health department, the FQHC, dental services, all need to be aware of the services that each offers so that we can have more of an active referral process as opposed to passive. So we're really working with those families to try to coordinate as much as those services as possible. The community health workers come in and help with that a lot, because they should be very well connected and understand the services that each entity offers. And then kind of handhold the patients to be able to utilize all of those services.
Great. Thank you.
One of the advantages of our housing authority here is that they also transport their residents. If there's a health fair, there's things going on, they have their own transportation, like fleet buses, where they'll transport, because transportation still remains an issue for us with residents in the housing authority for many of them. So that's an advantage, because in order for them to get to one place and the other, our mobile unit may not come as frequently as they need it, but the housing authority can then transport the clients as well. I don't know if your housing authority, Rod, has that capability or not, but that was another thing that came in handy for us.
I can certainly check with them. Thank you.
David B., I think you had a question about the profile of people who qualify as low income. I think I forgot the context on that. Do you want to follow up with that?
Yeah, about all programs, it's possible to know is the profile about these clients or patients, whatever. They need provide or proof they are low income.
Oh, so specifically for which program?
Weak housing weak program.
Okay, yeah, I guess that is a good question. Yeah.
Yes, so I guess I should have explained what the WIC program. So it is a special supplementals program. So the low income is considered 85% below the federal poverty guidelines, and so they do have to show proof of income. And it's also based off how many participants are in the home. So if mom is pregnant, that will count as 2 people. If it's mom and 2 children and she's pregnant, that will be 4 people. So it's based off income guidelines and the amount of people living in the home.
I have a question for Jason. You were mentioning that I think it was was it the Strong Families Initiative that is your primary area of focus? Like that and the Jobs Plus program, some of the information you put up. Is this an area where health centers can be involved in? Can they either by themselves or in collaboration apply to grants? And if so, how do those typically look?
Yeah, great question. So we have 2 programs that have family in the name, so it could be confusing. HUD Strong Families is sort of our umbrella program for all PHAs. FSS, which is the Family Self-Sufficiency Program that I work on, is a funded program, so they have to apply for that. And we have about 700 PHAs and 750 grantees in total around the country there. With Jobs Plus, we actually have a local match requirement, and a lot of federal grants are like this, right? So we say, we will give you, $2 million, but you need to show that you can pull $500,000 from local match. And so that is a great opportunity. We often see, so you guys have been talking about transportation, right? That's one of our greatest unmet needs. And so we often think about transportation as, like a van, which you can actually buy using the Jobs Plus program, and some sites have done that. But it could also be things like electric car sharing. We've seen that happen in Stockton. They put together like an electric car sharing program. And what we've learned is whenever there's greater access to transportation, it means there's greater access to health services. So that's, I think, a really crucial way that you can think about maybe multi-sectoral partnerships. So, having a health provider and maybe a transportation provider and the housing authority, and all of that match, as long as it's non-federal in terms of its source, can be counted. So we require for Jobs Plus that there is a partnership with the WIB, so the Workforce Development Board, and you might know those as like the American Job Centers. That's our mandatory partner. We don't mandate a health partner, but we certainly encourage it. Other programs like Ross actually have focus areas. So when people apply for a Ross grant, they choose where they want to focus on, and they have to pick a couple of different areas. And one of those areas that actually, many folks select is health. And so in those instances, we hold them accountable to metrics around their ability to connect people to health resources. So there's going to be some built-in interest there from the housing authority. When it comes to FSS, I think, and that's, again, these programs all sound probably similar, and it's not so important, I think, for you all to know which one it is, just so much as to know, when you work with people at the housing authority, they'll explain where their funding comes from and what their needs are. But one of the advantages with FSS is that it's portfolio wide. So Jobs Plus is actually site-based, it's place-based, it's at a specific development, and FSS is portfolio wide. So when you work with a FSS coordinator, you have the ability to access, different communities across a location, whereas, it might be much more limited if you're working with a Ross coordinator or Jobs Plus. So, that's kind of, to me, they sort of hold the key to, connecting you with residents and opportunities in across the portfolio.
You mentioned when you were talking about the Jobs Plus initiative, you mentioned community health workers, and it's sort of it connected in my mind that this is a valuable thing to consider for health centers. Is how workforce development is expensive, and how are some ways that this collaboration could potentially help with that? Have you found health centers are utilizing the program in that way?
Yeah, so actually one of the great benefits, this was only a pilot program at 5 sites, and LA was one of those sites that I mentioned, but it varied. We had Akron and Baltimore and New Orleans and Chicago, so different geographies and populations. And what we found is that a lot of health partners actually ended up taking those folks on. It was a 50-50 collaboration, so 50% seed funding from the Office of Minority Health at HHS and 50% local match. And a lot of those health partners are taking those folks on full time. And I think the reason is that you're right, there is a lot of sort of initial cost and maybe concern around, recruiting the right people, hiring the right people. But I think they realized even without that seed funding, the Jobs Plus coordinator could help them connect with residents who were already motivated, who were, had some training and background and can meet the qualifications that were necessary for the position. So, in Ohio, for example, you can't be a smoker, right? And the housing authority through Jobs Plus, they've already been working with residents, right? So they can help ensure we're not going to refer someone who's maybe currently going through smoking cessation, and that's going to be a challenge for them. In LA, they realized, a lot of folks have been going to the ER across the street versus the FQHC, down the road. And even though it was a little further away, there were some issues with scheduling, and people have big families and having to come back and take time off work. And, as they deepened the partnership around CHWs, they found they were able to get more patient population in at the FQHC. So that was a benefit. So I think, when it comes to, just because you hear workforce program, I would think of it as an opportunity to connect. And, you have somebody who's a built-in job developer sort of on site who can help connect you with residents who, maybe in previous time had worked in health or have an interest in health. And, you don't necessarily have to do all that sort of groundwork yourself, right? That's what these programs are there to help do.
So, Jason, when in managing this program and working with collaborations with health center and I'm sure housing agencies and so forth, what were the main challenges that they had in communicating and working with HUD?
Yeah, so one big challenge is just expectations, right? So I think, folks, are coming with their own, of course, lives and challenges. And this program launched during the pandemic. So in some cases, people dealing with childcare, which is, along with transportation, probably our number 1 and 2 biggest unmet needs. Dealing with just the pandemic, it made things very challenging, I think, when folks didn't have, for example, the connectivity at home. So we piloted a totally virtual community health worker certification training. And, through Connect Home, we're able to ensure people had laptops and hotspots. And, I think I mentioned earlier, FCC is promoting now a pilot program, and they have this affordable connectivity program, but that doesn't mean everybody has those resources, right? So just making sure that people have all the things that they need to be successful: childcare so that they can focus on the training, right? Connectivity at home so they can participate, transportation, and some health centers require folks to have a car, right? So they can be mobile around the community. So, working through those kind of things can be very challenging, especially during a pandemic, but folks were able to do it, right? So I hope no one hears that as like a reason not to try. It just means I think you have to be realistic about the needs that are out there, and the fact that very few people who are low income are going to come to your door without those kind of barriers, right? That's just the reality.
Jason, when what are from the perspective of the grant making process with really any HUD program? This might be a difficult ask, but is there, do you have any recommendations for health centers when they're applying for funding for HUD in any program, or other government agencies that you have insight into?
Yeah, so I mean, one thing I can say is, a lot of money gets put out there. Again, I run the FSS program. I actually, a lot of what we do is write the NOFOs, the Notice of Funding Opportunities, and evaluate the applications. And this seems very simple, but I think by and large, people often miss it, is they just don't look at what the agency is trying to do. They look at what they're trying to achieve. And, that's great. You all have your own local goals, and that's fantastic. But by law, we have to evaluate based on what our sort of structure is. So if Congress gives us money and says it has to be used for X, Y, and Z purposes, we're going to make very clear in the NOFO that that's how we're evaluating these applications. And I think the more that you, even though it's more work, can sort of customize and shift what you're asking for to meet that criteria, you're going to be much more successful in getting the funds. I think where we see people being less successful is when they sort of have like a bunch of blanket statements that a grant writer put together, and they just throw them and just see what sticks. And maybe that works, but it doesn't really usually fly for us, because we can very quickly see where it just doesn't really meet what we're asking for. So it's a little bit more time, but I would also say we always give folks debrief opportunities and feedback when they don't get funded. And not a lot of people take us up on that, but I think it's something that if you are looking for grants and you don't get something, to take advantage of that. Many of our grantees are folks who did not initially get funded on an application, debriefed, we kind of gave them the feedback, and they came back the second go around and got it. So, I would also encourage you not to think of these as like, oh, we have a deadline, we need to get the money for next year, but as a longer term, what do we need to do to prepare, apply, that could take some time. And then eventually, once we do get the money, ensure that we're renewed or, meet whatever requirements are there. And of course, happy to have, follow-on conversations with folks who are more interested in that.
What's interesting about that, Jason, is I think when we're writing grants, at times we get very focused on our own perspective and how we can communicate that. But there are needs that HUD has and the applicant has here. HUD needs to give out its money in an appropriate way according to its restrictions in the law. And keeping that in mind, it seems like it should be part of the process when we're writing a grant application, as in like, let me think of this again, but from the perspective of the funder.
Yeah, and I would actually say one program I didn't talk enough about or probably mention at all is actually one of our biggest programs, has $500 million, Choice Neighborhoods. And that you may have heard of Hope 6 in the past. It's sort of an evolution of that program. That is a comprehensive sort of community redevelopment. So we look at, ensuring that maintenance of the number of units so that everybody who wants to return to the community can, and doing it in a phased approach so that there's minimal displacement. But also there is a people component to that physical redevelopment. And part of that is we recognize that any sort of redevelopment is going to have impacts, and we try to minimize those impacts through human services. So that's a program where you could easily plug in. There's a health component to Choice Neighborhoods. And what they're really good about is they've moved to a model of doing planning and implementation grants. So getting people to apply for a planning grant that gives them a small amount of money to then work with their partners to put together the larger implementation grant proposal and to be more successful in those applications. And I think that's a really good model. So, Choice Neighborhoods is a program I definitely encourage folks to look at, and to look at being part of that planning process, even though, again, it takes a few years to go from planning to implementation, but, the money is there to back it up. And we've seen that can be a really lasting impact in terms of partnerships that are created, often are sustained after the redevelopment because, you're used to working together, right? You have a good working relationship at that point.
And I think the collaboration with WIC that we went through that included the dental services being added on top of that is a good example of how these are like very much like human relationships. If you have a good experience with someone, you're probably more likely to want to spend more time with them. And I think these collaborations have a very an obviously human element that we sometimes forget about because they're big organizations. But you folks have built on top of your collaboration as well, adding services as you, in many ways, create an infrastructure for accessing the community. So it drew a really like incredibly detailed picture of like meeting your community needs that I really appreciate. And Jason giving the inside perspective of how HUD looks at collaborations and what it values, and really the grant perspective of what their perspective is. Has certainly been valuable to me, so I appreciate that. And we are right at 3:03, a little over. I guess if anyone has anything.
Well, let me just also close out on adding to that, you know, I have worked directly with dozens of grantees as a grant manager, and I can count not even on, you know, less than one hand, the number of people that I've started working with at the beginning of a grant who are still there at the end of a grant. There's a lot of turnover on the ground. And so I think what's challenging about partnerships is you build these individual relationships and, you know, it kind of, if those people move on, if they're successful, right, they may move on to other opportunities, and then it can feel like you're starting over again. So I would encourage you all also to think about, and I'm sure we'll talk about this in future sessions, ways of institutionalizing the partnership so it doesn't just depend on having those two people with that trust built in, but that it can continue, you know, in a long-term sustainable way.
Institutionalizing partnerships. Thank you for that, Jason. Rod had a question that if we'll have an opportunity to talk with our content experts today, if you have additional questions moving forward. Matt, if they want to be connected, what's the best way for us to manage
Yeah, we are going to, we'll be sharing now all the contact information, the slides, the recording of this presentation as well in the next day or two. So you'll have the opportunity. You also have my email in doing so. So if you need any further assistance in connecting with one of the presenters, and I believe that some, if not all, of the presenters will be back in the future sessions to present as well. So if you continue on this learning collaborative, you'll have more opportunities to talk with them and engage with them. And I want to thank everybody today for joining us, the attendees and especially the speakers. And again, well, thank you, Jason, for dropping your email in the chat. It's a great idea. And but yeah, we'll send out an email follow up today with the next steps and the information on next week's learning collaborative. And it is the same link, I believe, as this week's. So thank you again for joining everybody, and stay tuned for an email with next steps on next week's learning collaborative, and also a recording of the session, presentation, and all the resources you'll need that you heard about today. Thank you.
Thank you. Appreciate it.